The Gerontological Society of America, Meaningful Lives as We Age.
Welcome to this GSA Momentum Discussion podcast episode titled Achieve, a landmark study of the effect of hearing intervention on brain health in older adults. Momentum discussions highlight topics experiencing great momentum in the field of gerontology. We're grateful to Genentech, Lilly, Eisai, and Otsuka for their support of the GSA Care Toolkit for Primary Care Teams and today's podcast episode. My name is Jen Pettis, and I'm the Director of Strategic Alliances at the Gerontological Society of America, or GSA, and I'm pleased to serve as the host for today's Momentum discussion. I'm so happy to be joined by Dr. Frank Lin of Johns Hopkins University School of Medicine and the Bloomberg School of Public Health, who is the co-primary investigator of the Aging and Cognitive Health Evaluation in Elders, or ACHIEVE study. This study is a multi-center randomized trial to determine if treating hearing loss in older adults reduces cognitive decline that can occur with aging. Dr. Lin and his co-principal investigator presented their very exciting findings at the Alzheimer's Association International Conference in 2023, and I'm delighted to have this opportunity to chat with you, Dr. Lin, about these findings and some exciting next steps. Welcome, Dr. Lin. I'm so glad you're here.
Thanks so much for having me, Jen.
Well, Dr. Lin, to start, can you provide our listeners with a brief overview of ACHIEVE? What did you and your colleagues examine, and what did you find?
Yeah, thanks for the question, Jen. So, going back over a decade now, there's been this body of research building that looking at observational epidemiological studies, studies of older adults followed for many, many years, have seen this clear connection between the level of hearing loss, basically someone's hearing levels, and then the risk of being diagnosed with a cognitive decline or dementia over time. And, these observational studies have been very suggestive. They've been across many different countries, many different neurocognitive assessments, people basically in their 60s and up. And consistently, these studies have shown that, greater hearing loss is associated with a greater risk of cognitive decline or dementia. And it's interesting, of course, because there are potential mechanisms that link hearing loss with dementia, which always suggested then that, well, maybe something as simple as using a hearing aid, basically getting and treating your hearing loss, it could, in fact, lower that risk of cognitive decline or dementia. But we never knew if that was the case, though, mainly because these were essentially observational studies where if people did use hearing aids, they on average did better than people didn't. But was it because of the factors that led them to get a hearing aid? People who get hearing aids usually, honestly, healthier, wealthier, and better educated. So you couldn't disentangle whether it was the hearing intervention or the factors that led them to get a hearing aid. So the ACHIEVE trial was basically a definitive randomized trial designed to ask that very basic question, namely, if we treat hearing loss in older adults and treat it well, can we in fact reduce rates of cognitive decline or dementia over a 3-year period?
And what did you and your colleagues find?
So the trial itself, this was it was funded by the National Institute on Aging, and what we did in this trial is we enrolled nearly 1,000 older adults across the United States, 4 different study centers across the United States. And we recruited these people from 2 different study populations. About a quarter of the sample came from an existing study called the Atherosclerosis Risk and Community Studies, called the ERIC study. And the ERIC study, they recruited a random sample of the population nearly 30 years ago when they're midlife. And they've been just conveniently followed to the present day to basically look at how midlife cardiovascular risk factors may be associated with later life cardiovascular disease. So basically, the ERIC sample came from essentially a random sample of the population recruited 30 years ago, followed to the present day. The other 3/4 of the cohort came from essentially new healthy volunteers between 70, 84 years old who were interested in joining a healthy aging study, right? Everyone in the trial then, there's nearly 1,000 people at the beginning of the trial, they were randomized, flip of a coin. They either got hearing intervention or they basically got a health education control intervention, basically meeting one-on-one with usually a certified health educator to go over topics around nutrition and diet, exercise, and things like that. So basically both groups of people basically had the same amount of exposure to study personnel. And that's important because just by seeing, let's say, the audiologist, for instance, that could be good for you by just having more contact with study personnel. So we controlled for that. So that was the beginning of the study. They all got hearing intervention versus the health education control. Everyone was then followed every 3 years. Every year, we assessed their thinking and memory abilities with a comprehensive neurocognitive battery. And mind you, this neurocognitive battery, it was primarily visually based. So it wasn't that someone couldn't hear the examiner, for instance, whether they're doing better or worse, for instance. These were basically primarily non-auditory measures of cognition. After 3 years, we looked at the data, and lo and behold, what we found is that among the group of older adults who came from ERIC, which basically represented a random sample of the population 30 years ago, is that we saw that hearing intervention was associated with nearly a 48 to nearly 50% reduction in the loss of thinking and memory abilities over 3 years. So basically a 50% reduction in the rate of cognitive decline just over a 3-year period, which are really, honestly, remarkable results in the scale of the magnitude of what we saw there with the effect of hearing intervention on the rate of cognitive decline.
So, Dr. Lineage, you think about those results, and what is it really that link hearing loss to cognitive decline? What are the mechanisms in the brain that really make that link?
So there have been a few that have been hypothesized, and it's likely not that one's right, the other ones are wrong. It's like a combination of all three. The first one is basically the idea of cognitive load, and what I mean by that is that when we talk about hearing, hearing really occurs in two steps. Sound has to be encoded by the inner ear, and as signals are sent to the brain for decoding, right? So what happens is all of us develop some hearing changes as we get older, mainly because the inner ear progressively deteriorates over our entire life. It can't regenerate. Is that the inner ear is constantly sending a much more garbled sound to the brain. So whether the brain, in fact, actually has to constantly, you put it, reallocate brain resources or constantly, reallocate brain energy per se to dealing with hearing, to basically dealing with a much more degraded auditory sound, and then may come at the expense then of our thinking memory abilities. So it's not so much that in this mechanism of cognitive load that hearing loss causes or cause dementia. It's more that's associated with earlier exposure of dementia symptoms and cognitive decline. And that's because that cognitive buffer, also called cognitive reserve, which we all have to some degree, rather than that being available to help buffer against other pathological contributors to dementia, things like Alzheimer's disease and vascular disease, that buffer is instead being used up by having to compensate for the degraded hearing coming from the inner ear. So that's one mechanism. It's the idea of, again, we call it cognitive load, the cognitive load hypothesis. A second mechanism, it actually sounds similar, but it's actually very, very different. And it's the idea that hearing loss in of itself may lead to or trigger changes in terms of the brain structure and hence the brain function. And what I mean by that is essentially if you have constantly having some degree of auditory deprivation, the inner ear is constantly sending a much more degraded signal to the hearing parts of the brain, whether in fact you see faster rates of atrophy over those parts of the brain, which can then have cascading effects on other areas of brain function and structure. And actually, we see that. We see that both in animal models as well as human studies. People have been followed for many, many years, comparing those who have some hearing changes versus those who have quite good hearing. And you see over time that people who have degraded hearing literally have faster rates of brain atrophy parts of the brain that handle sound and also language processing, but which also subserve areas of thinking and memory abilities too. So it's the second mechanism, this idea that hearing loss may lead to direct change in terms of brain structure function. The third hypothesized mechanism is going to be most intuitive, and it's the idea that for any given one of us, that if we develop some difficulty with hearing, struggling hearing a bit more in group conversations, that we're less likely to be socially engaged. Or even if we are engaged, we may not be as involved in that conversation. We may feel a little more isolated, lonely, for instance. And we've long known that remaining cognitively stimulated, remaining stimulated with socially and also with others is incredibly important for our brain health. So it's a combination of all three. It's not like one mechanism is right, other ones are wrong. It's likely a combination of all three. And those mechanisms you can imagine, Jen, are really important is because they suggest that, potentially using a hearing aid, learning how to use it well, may be able to modify those mechanisms and hence reduce cognitive decline, right? And indeed, that may be in fact what we're seeing now with the ACHIEVE study.
So, when primary care teams and other healthcare providers are using your findings and talking about the potential with hearing aids, how might they talk to their patients? How might they use your findings and your advice around hearing aids to talk with their patients?
Well, I think this is one of the fortunate things about sort of idea of addressing hearing and hearing intervention is that, the whole reason to address hearing and to care about it, don't get me wrong. I think from the Alzheimer's disease standpoint, the results that you saw are incredibly fascinating. They're really important for understanding our idea of how dementing illnesses work and the brain works. But at the individual clinical level, honestly, I mean, the idea of treating hearing loss has much more tangible proximal effects. I mean, the fact that you may not be struggling as much in conversations, you're able to engage, it would be more yourself. Safety reasons, even if you're having trouble hearing like surrounding traffic while you're driving or walking. So there are very, very immediate tangible reasons to think about addressing your hearing, treating your hearing over and above and beyond this, I would say, a theoretical benefit on cognitive health over time, which also makes complete sense, by the way, right? So I think fortunately at the clinical level, there's immediate tangible benefits that you'll notice within days or weeks, right? As opposed to this theoretical benefit, maybe it potentially at the individual level could reduce risk of cognitive dementia. We can never predict that fully at the individual level, of course, from a clinical trial. But over and above that theoretical benefit, there are real tangible benefits to addressing any type of hearing issues and to optimizing your communication. The good news there too, of course, then too, is that the idea of quote unquote hearing intervention, for instance, as using a hearing aid, it doesn't come at any medical risk, right? So there's literally literally zero medical risk with addressing and treating your hearing. There are only potential benefits on helping improve communication, frustration with communicating with others. And oh yeah, there could be this theoretical benefit of promoting and supporting cognitive health over time. It's sort of a no-brainer in many ways when you put that calculus in mind. And you're speaking to other hat I wear as a surgeon and as an ENT and otologic surgeon, everything I think about from a clinical point of view comes out of risk versus benefit. If there is potential benefit and there's essentially zero risk, then it's sort of very easy, right? In contrast, obviously, the type of risky therapy, some type of drug therapy that can be risky and there's maybe some benefit, then the calculus gets much harder. In this case, I think the calculus is actually quite easy, in fact, given the evidence that's been growing to date.
So, Dr. Lin, you've talked a lot, mentioned the benefits and certainly the cognitive, slowing that decline by 48%. Why do you believe that potential is there to really reduce that rate of cognitive decline in individuals with hearing loss? What's the why? What's the science behind that?
Well, I think the ACHIEVE trial, I mentioned before the three hypothesized hypothetical mechanisms linking hearing with cognitive decline or dementia. And you would think then, at least what we're thinking the ACHIEVE trial is that the effect we're seeing of at least among the error cohort, which represented a random sample of the population, which was on average at higher risk of cognitive decline dementia than the healthy volunteers. But we're seeing in the error cohort specifically, that essentially that nearly 50% reduction in cognitive decline is we think it actually may be operating through those mechanisms. And to date now, we've done some a couple of additional analyses, and these are papers that are currently in preparation right now, is that we're seeing with when we do measures of social isolation and loneliness, we're seeing that the hearing intervention versus control is actually having a positive effect on reducing social isolation and loneliness over a 3-year period. So that gets at that mechanism of social engagement being possibly a mediator between hearing loss and cognitive decline dementia. And what's really interesting too is in the ACHIEVE trial, we also gathered brain MRI data on a half sample of the participants. So basically, roughly half the 1,000 people got MRI scans at baseline and then 3 years later. And we actually look at the MRI data from baseline to 3 years. We're actually seeing a positive effect of hearing intervention there as well. Now, it's not definitive. It wasn't meant to be a definitive outcome, but we're seeing over a 3-year period a very, very clear and strong signal that hearing intervention is having a positive effect on reducing rates of cortical thinning of the actual cortex of the brain over just a 3-year period. So far, at least on the data, it suggests that these mechanisms may, in fact, truly be modifiable with hearing intervention over a 3-year period. That's really important, right? Because you could say these mechanisms are in play, but maybe hearing intervention, something as simple as using a hearing aid, which is not reversing hearing loss. Your hearing loss is still there. It's not like making it go away. But we're seeing, I think, essentially relatively strong evidence at this point already that the hearing intervention may, in fact, be able to directly modify those pathways where you actually have a tangible and measurable, demonstrable benefit within just 3 years, which is really, really exciting to see because we don't often see that with other therapies in the Alzheimer's disease and related dementia space.
That's so exciting. And like you said, no risk for the patient, nothing to lose to give it a try. It's really incredible. And I do understand because of these incredible findings that you're going to launch a broader national campaign later this year that really encourages older adults to check their hearing and learn what their hearing level is and monitor that with a free app hearing number. So what does hearing number tell someone and why should they be testing their hearing routinely?
So Jen, this is such an important question. And the reason why is that, as a I would say first and foremost, I'm a clinician, and secondary, I'm a researcher. And what I mean by that is that research, I think for a lot of what I do is a means to an end to quote unquote help the patient I see on a given basis, right? So research doesn't always directly lead to benefiting that patient I'm seeing in my clinic tomorrow morning, for instance, right? So, everything I've ever done at Hopkins is revolved around 3 different things. And it's basically the context of the evidence, policy, and awareness. So research evidence, policy and awareness. And what I mean by that is, I think with the ACHIEVE trial, all this data that we have to date, we're seeing without a doubt the strong evidence that hearing loss has a meaningful effect on people's lives, and more important, that hearing intervention now shown through the ACHIEVE trial can also have a meaningful effect on reducing said risks, improving cognitive public health over just a 3-year period. So that's great. Evidence is there. At the same time, then, as probably many of the listeners are probably aware now, is hearing aids are sort of ridiculously expensive. I mean, the average cost for a pair of hearing aids a few years ago in the United States was still around $4,000 for a pair of hearing aids, which is usually out of pocket. And to put that in perspective, that means for the average American, a simple pair of hearing aids may be your third largest material purchase in life after a house and a car, which is fairly absurd, and it doesn't follow from the evidence. If hearing is so important and these therapies are so expensive and not covered by insurance, what gives? So, fortunately, one piece of actions that's changed in the last 5-6 years is working several years ago with the National Academies in the White House. We actually got a law change in the US called the Over-the-Counter Hearing Aid Act, which was passed in 2017, which went into effect about almost a year and a half ago now, which means just now beginning the states now, you'll see this over the next few years, is that the over-the-counter hearing aid market is rapidly developing. So basically the idea that a pair of hearing aids can be purchased over the counter, much like you purchase a pair of wireless earbuds. I mean, that is evolving very, very quickly in the next few years. And that makes it really exciting that these technologies can be much more accessible and affordable than they have in the past. And we're just beginning to see that market develop now, but it'll still take a few more years for that market to fully mature and get to steady state with the pricing and everything like that. The last thing, though, is that, as I talk about, evidence, policy, awareness. We have evidence, hearing supports, and we have policy now. It's created affordable, accessible, innovative solutions that are just being evolved now. But the amazing thing, Jen, though, is that this awareness piece is that I'm guessing, and you don't have to answer this, but among most people I talk to, the last time anyone ever got their hearing checked or tested, probably when they're 7 years old in primary school, right? So that's a problem, right? If hearing is so important with this wonderful solution, but if no one actually even knows what their hearing is, well, it doesn't really matter. So a big thing we're working on now, we've been working for a year and a half now. We'll be officially launching a national campaign, actually, in the United States. That'll be coming up at the Johns Hopkins Bloomberg School of Public Health later this year. It's called the Hearing Number Initiative, or the Hearing Number Campaign. And it's the idea that for any given person out there, beginning as a teenager, once a year on your smartphone, you should be able to measure your hearing yourself and track your hearing number yourself, much like you might know your blood pressure, your weight, your step count, your glucose, and you track every now and then yourself. You can just track your hearing yourself so you can understand how your hearing changes. The hearing number in that term is just a simple way of saying the technical term would technically be the audiometric 4-frequency pure tone average. That's a bit of a mouthful, hence we're calling it the hearing number. And what that audiometric 4-frequency pure tone average, or PTA4, actually is, it comes from your audiogram. It basically, audiogram, as you probably know, it measures how loud do different sounds and different pitches have to be for you to hear them. And the 4-frequency PTA, pure tone average, is basically an average of how loud do the speech sounds, basically between 500 and 4,000 hertz, have to be for you to hear them. So if your hearing number, your PTA4 is 0, that basically means you're able to hear really, really, really soft sounds. But as that number gets louder, it basically means on average, speech sounds have to be louder for you to hear them. So everybody at birth usually roughly starts around a 0 or 5, or maybe even a little better than that on average, right? But as we get older, and I mean essentially after puberty, everybody's hearing begins slowly declining a little bit at a time. And that's because the inner ear is all made up of cells that are post-mitotic. They can't regenerate. So everybody essentially over a lifetime, everybody loses some hearing every time. But a lot of times you don't notice it because your brain compensates for it in a good way, but also possibly a bad way, right? If your brain's constantly compensating for that, may come at a cost to the brain, and you don't realize it. When you actually track your hearing number over time, though, you actually see and you can observe, much like you might notice your weight going up a little bit or something like that, your blood pressure creeping up a little bit, right? When you track that number, you understand something is changing, and hence it can inform you about things you can do to either protect your hearing and, or more importantly, to possibly optimize your hearing through adopting certain strategies or technologies. So right now, that hearing number, and we actually have a website now for listeners who are interested, it's just hearingnumber.org, and this is a school public health website. There are ways you can measure your hearing number on your phone right now. Right now, it's only possible on a Apple iOS platform. So there are a few different apps you can do on an iOS platform. But what we're doing later this year is we are launching at the School of Public Health our own app. It'll be the Hopkins School of Public Health Hearing Number app. It'll be completely free. We're not collecting any data. It's purely meant as a public service. We're on an iPhone or a compatible Android phone. You'll actually be able to, in about 3 or 4 minutes in a quiet room, you can just measure your hearing number yourself, and you can just track it over your lifetime to clue you about what you can do about your hearing as all this older. So you don't have to go see me as an ENT surgeon. You don't need to see an audiologist. Just 3 or 4 minutes and quiet in a private room in your house, just measure your hearing number yourself. And I'll put this in perspective why this number is so important is that, for example, I'm 47. And if you had asked me a couple of years ago, even now, like, how's your hearing, Frank? I'm like, my hearing is great. It hasn't really changed at all, right? And honestly, I sort of feel that way, right? But a couple of years ago, I measured my hearing number on my phone. So it was the iPhone back then, and my hearing number was a 10 in my right ear, 12 in my left ear. And from that perspective, anything less than 20, according to the World Health Organization, is considered quote unquote normal, right? And if you're between 20 and 35, it's sort of mild hearing loss and so on and so forth, right? So 10, 12 is firmly in the normal range. So I was like, oh yeah, that makes sense. My hearing is great. And has my hearing changed? No, I don't think so. My hearing is great. But then I had back then she was 16, my daughter. I asked her to do her hearing number on her phone, and hers is a -3.
Oh, wow.
And when I saw that, it was really eye-opening for me. And the reason why it was eye-opening is because if you'd asked me, is my hearing worse than my daughter's? I'd be like, no, of course not. We're the same, right? But when I saw hers being a -3, so I'm 15 decibels worse than her, that's a big difference, even though, quote, unquote,
Wow.
both normal. I was like, huh, I guess my hearing really has gotten worse in the sense that if I use it as a prop for me, I'm pretty sure back then, I should have known this, I was probably around a 0 back then too. But I've declined 15 decibels, even though I'm considered normal still. And the more I think about it, if I know for a fact, if I'm in a busy restaurant with her where it's a little harder to hear, I know for a fact she hears better than I do, right? And it's because my hearing has changed. I would never consider myself quote unquote I have hearing loss, right? But I do, in the sense that that's why I hate the term hearing loss in general. Hence, a hearing number is getting sort of really doing away with that term because it's not whether you have hearing loss or not. It's not all of a sudden one day you wake up with it. It's just like, what is your hearing? And yes, your hearing changes over time monotonically, basically meaning it gets a little bit worse all the time, just as we all get older. So knowing my number now in that sense has just really changed the way I think about my own hearing. And you're speaking to someone who is like a hearing researcher and a clinician. And it's just that objective neutral metric has changed how I think about my own hearing. And that even my stage now being 47 with, by all intents and means normal hearing, I know for a fact now there are certain strategies and technology I can't even begin to adopt. So it changes the perspective. All of a sudden, hearing loss becomes one of those things that you're trying to avoid. That one day you may or may have developed to becoming like, and also, it becomes a life event to think about treating your hearing loss. Literally, you have to go get a hearing test and get a hearing aid. So it's literally a life event. So if you start thinking about hearing as this continuum across your lifetime, that does change a little bit. You monitor it, and incrementally, like over time, you can begin adopting various technologies and strategies to help you optimize your hearing. And that's really going to be changing very quickly in the next couple of years as OTC hearing aids become rapidly and integrated within our existing smartphones and our existing wireless earbuds. That, is that person using a pair of wireless earbuds or are those hearing aids? It's one and the same, right? And that's when things get really, really interesting. So that whole hearing number campaign, it is rolling out end of this year, probably around Thanksgiving. So hopefully, depending on how big we go with the budget and other people may be partnering with us, you may be seeing ads about it in your pop-up, your feeds and things like that, maybe possible potential billboards, encouraging people to just download this free hearing app and just track your hearing much like you do any other health metric.
Well, we'll look forward to integrating it into the GSA Care Toolkit for sure to raise awareness among primary care as they're talking about brain health. But how can clinicians use that hearing number to help their patients and caregivers really understand and contextualize their hearing?
Yeah, so I think the big thing there is, and we have this. If you look at the hearing number site, there's this grid that gives you, like, depending on your hearing number, what you can do. So I'll say any hearing number, whether you have perfect hearing, like my daughter essentially, or me, where my hearing is clearly beginning to change, is that if the goal is fundamental goal of all of this is to really, I would say, optimize communication, optimize safety, there are a few things at any given hearing number you can do something about it. What I mean by that is any hearing number, you can always protect your hearing, right? And what I mean by that is, in general, the rule of thumb is if you are at arm's length with somebody and you have to raise your voice to be heard, right? That's a situation where you probably should consider using hearing protection if you're going to be there for a long period of time. Obviously, just walking through the subway, don't worry about it. If you're working down like in a subway all day, 8 hours a day, you should probably use a hearing protection because those are situations where you have to raise your voice to be heard at arm's length away, right? Likewise, using a lawnmower, yes, absolutely. If you're just walking by a lawnmower, probably not, right? But that's a good general rule of thumb. You always protect your hearing. In the situation to protect your hearing, if it's too loud or you have to raise your voice to be heard at arm's length, you probably should use a hearing protection if you're going to be there long enough. Beyond that, any hearing level, communication strategies. Anytime you can be face-to-face with someone in a quiet room, turn on the background noise, you'll communicate a lot better. That's whether it's a patient. If you're with a patient who's having trouble hearing, arm's length, 3 feet away, face-to-face, turn off the TV, turn off the sink, and you'll be able to communicate better. So the basic communication strategies, anyone could benefit from. Beyond that, you consider any hearing level, basic communication, other sort of everyday technologies, right? Things like closed captioning. I use it all the time. People who make phone calls a lot, I'll tell you, if you're talking on a voice over internet protocol, a voice over IP service like Skype or FaceTime or Google or WhatsApp, anything that sounds transmitted over the internet as opposed to like a cell phone or landline call, the sound quality is a whole lot better because the bandwidth is bigger. So having a phone call in general over those services over a landline or cell phone call, it leads to a lot fewer questions and because the sound clarity is better. Then if your hearing number is between roughly, I would say 10 and a 60, that is clearly the range already where people can begin benefiting from over-the-counter hearing aid. Right? If you're in the tens like me, it's probably not all the time, but situational, incidental use. When I actually use these wireless earbuds I have right now, they have a conversation boost feature. So if I'm in a busy restaurant, I can put them on. I hear better, actually. So that's for situational use. A company coming out this year, the parent company that makes Ray-Ban Oakley, they're coming out with over-the-counter hearing aid glasses. They look like completely normal glasses, but whoever you look at in a restaurant is who you hear. I've actually tried them on. They work amazingly. So between 10 and 60 for hearing number, you can consider using OTC hearing aids, whether situationally, if your hearing numbers in the 10s or low 20s maybe, as you get to the 20s, 30s, 40s, you're talking about probably using OTC hearing aids a little more consistently, maybe almost every single day. If you're hearing between, we say roughly between 20 and 90, that's a level where you can consider prescription hearing aids. They're like going to see an ENT doctor or an audiologist getting professionally fitted for ones that, especially if you need more services, you need more counseling, you definitely want to go to a professional. And if your hearing number is 60 or higher, that's actually the level where you could begin considering a cochlear implant, actually, even, right? Cochlear implant being a surgically implanted device that directly sends sound to the brain. If you're still struggling with hearing aids and your hearing number is usually around roughly above 60, you're actually in the range where you consider cochlear implant. So I think the beauty of knowing your hearing number is that you can see how it's changing or hopefully not changing over time, right? And if it is changing over time, definitely consider using more hearing protection. And at any given level, you can consider various technologies or strategies to help you optimize your hearing. The amazing thing is that if you don't know your hearing number, you're sort of in the dark of where you are or what you need or something like that, right? So the hearing number, that in concert with just what you're experiencing in your day-to-day situations can completely clue you into what to do next a lot of times.
Well, earlier I had the opportunity to review your terrific article that was published last week in the New England Journal of Medicine. And in that, you presented some various evidence-based strategies and clinical recommendations to address age-related hearing loss. Can you share a few highlights?
Yeah, Jen, thanks so much. Yeah, so this was a piece that was published in the New England Journal back on the 25th. And it was a clinical practice piece they asked me to write around specifically age-related hearing loss and, how I would manage it, and what to do about it and things like that. So it was really just a clinical summary piece. I think it was relatively short, 2,500 words, if I recall, so not too long. And really a lot of the piece is really built around consumers or patients knowing their hearing number, right? Because as a clinician, I can tell you, if you know your patient's hearing number, just if they tell it to you, automatically clues you in how you need to communicate with that patient, right? If their hearing number is like in the 10s or 20s, you can pretty much have a normal conversation. By the time you get to the 30s and 40s, a little higher, sometimes like if you're not making face-to-face communication with that patient in a clinic room, they're probably hearing what you're saying, but they may be missing quite a bit of it. So, classically, and in my clinic too, since I try to turn my back when I'm using the computer or something like that, for someone with great hearing, you can get away doing that. Someone with hearing number in the 30s, 40s, and 50s, I tell you, if I'm doing that, they are probably trying to fill in the gaps, right? So as a clinician, it clues you in to what a patient needs in terms of how you communicate with them just on a day-to-day basis. More importantly, I think as a clinician too, knowing the hearing number, if we really do believe in fact that hearing loss is like one of these other key risk factors for cognitive decline dementia, much like high blood pressure and diabetes and low education, that's something we need to know about to guide our patients, much like you probably measure your patient's blood pressure to advise them about around hypertension and avoiding possible complications of hypertension. I think hearing in the same way is the same sort of thing, being included about what patients need in terms of potentially their hearing communication needs, especially if those interventions could potentially have a benefit on things immediately, like on things like communication, but even potentially downstream effects on promoting cognitive and brain health, right? So much of the article is really built around the idea of the hearing number and how if patients knew it, if doctors knew it, it can really allow for a much, I think, patient-centered higher level of care that can lead patients to solutions, interventions that can improve, honestly, their everyday lives, most importantly, and possibly have downstream effects on other outcomes as well. So yeah, a lot of that article is written around the idea of the hearing number, where patients can get it, as clinicians, what to look for, how changes in hearing present, what it means, and then tying that into different situations and obviously different solutions as well.
And when you begin that article, there's a vignette of a husband and wife. And so that brings me to my last question is, so many times it's one, right, convincing the other to talk to the doctor about their hearing. So finally, Dr. Lin, what can family members do to support their loved ones with hearing loss and convince them to wear the hearing aids if appropriate?
Yeah, so Jen, it's how that vignette began. It's a classic presentation we're all familiar with. It's usually not so much a person whose hearing is changing is noticing the problem. It's all the person's family members, right? That's usually always how it is. So I think a lot of that. That's why I think the hearing number is so important. Is for anyone experiencing hearing changes, and let's say I'm one of them, right? If you ask me, I'm like, oh, my hearing hasn't changed, right? Because you don't recognize, because your brain accommodates for it, and your brain, but that accommodation per se could come at a cost, in other words, right? I think that's why the number is so important, is because as individual with any type of change in hearing, short of you're really getting to the point where you're in the moderate or severe range, you may not realize it's easy to attribute to others. Oh, my wife's not speaking clearly. It's these kids nowadays. The acoustics of this room are terrible, and all are a bit true, right? Because ultimately our hearing experience is dictated by not only our own intrinsic hearing of our ear, but it's also dictated by the sound quality coming in. So the sound quality comes in great, even with some hearing loss, you're not going to experience any functional difficulty. But if you have some hearing loss and the sound quality is sort of poor, then you really struggle, right? Whereas your hearing was perfect, sound quality is poor, you still get by perfectly fine, right? So it's so easy to attribute to external causes and not realize that part of the problem per se is also with your intrinsic hearing, right? And I think that's why the number is so important in that regard, is that it can validate what is going on with yourself that you otherwise would be oblivious to, quite simply, right? So I think that's one of the first things, that you need some objectivity about it, right? Don't believe, if your father or your father-in-law or your spouse doesn't believe you, it's hard to argue against a cold hard number, right? And more importantly, with that number too, and with the understanding that people need to understand that hearing experience is really dictated really by two things: your intrinsic hearing, as well as the hearing environment, the quality of the sound. Right. So that's why someone will say, oh, God, Dr. Lin, I hear you great. You're fine. Right. It's because I say, well, it's not because I'm a miracle. It's just that I'm in a quiet room with you face to face. Whereas when you're talking to your wife, it's usually she's in the living room, you're in the family room, you're trying to have a conversation. Right. That's like the sound quality coming in is poor, but that's something they can do about. If you can optimize that sound quality coming in, irrespective of your own hearing, you'll do a lot better. And that gets at the communication strategies, being face-to-face in a quiet room, as well as thinking about then adopting hearing technologies, hearing aids, and things like that can also further optimize that sound quality. So I think the understanding there is key about why people have hearing problems. It has to do with the intrinsic sound quality coming in, as well as the person's intrinsic hearing. You have to know both or be aware of both to help optimize someone's hearing.
Well, Dr. Lin, I know you're awful busy, and I really appreciate your time to join me today for the podcast. But most of all, I want to thank you for the amazing work that you do to promote wellness and safety and quality of life for older adults by addressing their hearing. So thank you also to those who were able to listen to this episode of the Momentum Discussion Podcast. We hope you found it informative and enjoyable. And many thanks again, Dr. Lin.
Thanks so much, Jen.
The Gerontological Society of America was founded in 1945 to cultivate excellence in interdisciplinary aging research and education to advance innovations in practice and policy. For more information about GSA, visit geron.org. geron.org.